This is the Pick Your Poison podcast. I'm your host, Dr. JP, and I'm here to share my passion for poisons in this interactive show. Will our patients survive this podcast? It's up to you and the choices you make. Our episode today is called Burn. Want to know what toxin causes excruciating pain and death in minutes? Has been treated with amputation? And when petroleum jelly, brand name Vaseline, is used to treat poisoning? Listen to find out. You're working in the emergency department when you hear shouts for help followed by the sound of someone racing down the hall with a stretcher. You excuse yourself from the bedside of a patient with the flu. Several staff members run outside into the ambulance bay. Surprisingly, there are no ambulances. There is a beat-up pickup truck, and the driver is leaning across trying to push a man out of the passenger seat. Question number 1. This scenario often means A, a cardiac arrest, B, a gunshot wound, C, a drug overdose, or D, all of the above? The answer, D. It could be anything. However, if you work in an urban emergency department, this scenario usually means a gunshot wound. Victims are pushed out of cars speeding away from the ambulance bay, or the car and the patient are left as the driver runs away. This method, not recommended by myself, is nevertheless potentially effective for getting the victim medical care while avoiding law enforcement. I remember one morning as an intern after a very long, very busy night shift exiting through the ambulance bay to see 2 separate cars cordoned off by the police into 2 separate crime scenes. But that's not what's happening here. There's no blood, the passenger is unconscious, and the driver isn't trying to speed away, but pushing to help the nurse and the tech pulling from the other side to get him onto the stretcher. You meet them in the ambulance bay. The man is pale and unresponsive on the stretcher. Does he have a pulse? While palpating with your fingers on his neck, you ask the tech to bring the driver in. The patient certainly won't be able to give a history. Hopefully, the driver can tell us what happened. You feel a few weak thumps against your fingers. The pulse is present, though weak and thready, meaning he might not have it for much longer. The nurses cut off his clothes, hook him up to the monitor, and place 2 large-bore IVs. His vital signs are as follows: temperature 98.5 or 36.9 Celsius, heart rate 120 beats per minute, blood pressure 80/40, respirations 20 breaths per minute, and the pulse ox is 97% on room air. Your quick physical exam reveals he's completely unresponsive even to pain, with normal pupils and an otherwise normal heart and lung exam. To treat the rapid heart rate and low blood pressure, you tell the nurses to start 2 liters of normal saline. You order basic lab work, an EKG, and a bedside chest x-ray. With the immediate steps underway, you turn to the driver huddled in the back corner, asking how he knows the patient. He says they're friends and work colleagues. You ask him to tell you what he knows. He says the patient is 32 years old and otherwise healthy. He was fine at work this morning and without complaints. Just prior to arrival, they were transferring a compound from a larger bucket to a smaller bucket. One of the buckets slipped, splashing the patient from head to toe with the liquid. The driver grabbed a nearby hose and immediately washed the patient off with water. Despite this, the patient started screaming. A shiver runs through the driver as he recalls this. He didn't wait for an ambulance, but scooped up his friend into his truck and drove him here. About halfway through the 10-minute ride, the patient stopped screaming and lost consciousness. Question number 2. Are you and your staff safe, or are you all about to become contaminated and poisoned? A, true, it's safe to continue. B, false, stop for decontamination. C, who cares? The patient is critically ill. The answer is A. First, this is an important question. Think it's callous or selfish when the patient is critically ill? If you, the nurses, and the rest of the staff become poisoned, there will be no one else to take care of the patient, and that will not work in his favor. So regardless of his condition, we have to take a minute to think about decontamination. Most emergency departments have decon showers outside for potential chemical exposures. Do we need to take him back outside and shower him off? Fortunately, here I'd be reassured my staff is safe for 2 reasons. First, the driver washed the patient off with a hose prior to arrival. That's pretty much what we'd do in the shower anyway. And second, the driver himself is not sick. Not only was he at the scene, he hosed off the patient and helped him into and out of the truck. The driver says they were wearing rubber gloves and goggles, but otherwise regular work clothes. It's safe enough to proceed with medical care. You ask the driver what the toxic liquid was. Surely he knows, since they were using it at work in an occupational setting. Silence. A glance at the monitor lets you know the patient's blood pressure and heart rate are not responding to fluids. You ask the driver again what the liquid was. After several more seconds, he admits he doesn't know. Wait a minute, did I hear you say, that's not realistic? Sadly, it's not just realistic, but not uncommon, for a multitude of reasons we'll come back to in a bit. Essentially, we have a critically ill patient and absolutely no history. The first thing that comes to mind after someone is splashed with the liquid and starts screaming is an acid or a base. I'm sure you've seen horrific images of victims of acid attacks. You ask the nurse to help you roll the patient to double check all of his skin, but he doesn't have any burns or even any irritation on his skin. The tech rips off the EKG from the machine and hands it to you. It's a quick and easy screening test. That's the reason you ordered it, and you glance at it expecting it to be normal. You look at it, then look at it again to make sure you're reading it correctly. The QT segment is very prolonged. The QRS is starting to widen. Basically, it looks like someone has pulled both sides of the EKG and is stretching it out. Many medicines can cause this. We've talked about a number of them in the past. But this patient didn't suddenly have a side effect from a medicine or take an overdose. Another cause is electrolyte disturbances, including potassium, magnesium, and calcium. Just as you finish this thought, the monitor starts beeping. You guessed it, he's now in ventricular tachycardia, a lethal dysrhythmia. You check his pulse. This time, nothing. The nurses have already placed defibrillation pads, clearly aware of which way this patient was headed. You charge the defibrillator and administer a shock. His body jolts on the bed, but his rhythm doesn't change. You start CPR and epinephrine. While the nurses continue the advanced life support protocol, let's consider potential occupational exposures causing cardiac arrest. This is a huge list. There are many, many toxins used in occupational settings. And of course, any exposure that can happen at home can also happen at work. This isn't an internal medicine podcast, so we don't have hours to discuss the differential diagnosis. We have to work with what we have. Classic diagnoses we should consider include knockdown gases like hydrogen sulfide, which we discussed in the knockdown episode. Carbon monoxide exposure can certainly occur in the workplace. But the driver told us it was a liquid, and he was in the same room. He's clearly fine, so this rules out gases altogether. Hydrocarbons, including benzene, are liquid and are potentially lethal. But this scenario isn't right for sudden sniffing death. Benzene does cause a lot of toxicity, but it's mostly chronic because it causes leukemia. Cyanide, arsenic, and nitroglycerin are liquids. Cyanide fits with rapid cardiovascular collapse, though I wouldn't expect these EKG changes. And why was the patient screaming? Extremely rapid onset, severe pain, cardiac arrest, and EKG changes suggestive of electrolyte disturbance bring to mind one compound: hydrofluoric acid. Hydrofluoric acid burns, on the fingers especially, are not uncommon in the ED. Our patient doesn't have burns on his fingers. This is clearly systemic toxicity. And the very thought that this might be systemic hydrofluoric acid toxicity, to be honest, strikes fear into my heart, no exaggeration. But there's no time here for our feelings. We need to start treatment superstat. You ask the driver about hydrofluoric acid. He gives you a blank look. You tell him to contact his boss for more information. Question number 3. What is the treatment for hydrofluoric acid toxicity? A, calcium. B, milk. C, water. D, a base. The answer is A, calcium. Milk does nothing. Decontamination with water is correct to reduce the exposure, but it doesn't treat it. And it would be great if we could neutralize acids with bases like lye, but this doesn't work in reality, and you risk causing other serious injuries from the base itself. The treatment for hydrofluoric acid poisoning is calcium. How much? Basically, as much as you can administer as quickly as you can give it. This might be the only time in medicine when I wouldn't worry about the dose of a drug. Generally, we have 2 forms of calcium chloride and calcium gluconate. Calcium chloride has 3 times the concentration of gluconate. However, if you give it IV, there's a risk of cardiac arrest. So calcium chloride is only for patients already in cardiac arrest or critically ill patients in danger of developing cardiac arrest. In low-risk patients, we use calcium gluconate since it's much safer. The decision in our patient? That's easy. The code card typically contains one or both, as we used to routinely give it during codes, though this has since fallen out of favor. Your crash card has 5 amps of calcium chloride. You tell the nurse to push them all. I'd also call the pharmacy to tell them to send a lot more. After 5 amps of calcium chloride, this is a massive dose, by the way, we typically don't give more than 1 or 2, The ventricular tachycardia stops and the patient regains a pulse. Your own pulse slows down to a normal rate. The driver looks up from his phone. The boss texted back. The liquid is hydrofluoric acid, confirming your worst suspicions and shooting your own pulse right back up. The pharmacist runs into the room, arms filled with amps of calcium. You also order several grams of magnesium. If you can get a quick bedside potassium level here, it would be useful. Let's take a step back to talk about what hydrofluoric acid does and why it's so lethal. Normally, when we talk about acids and bases, we're talking about burns. Burns to the skin, like I mentioned earlier, or burns to the esophagus and GI tract after ingestion of a strong base like lye. The burns occur due to tissue destruction. Hydrofluoric acid can cause burns directly, but the main issue is actually fluoride toxicity. Side note, this is acute fluoride toxicity. It isn't what occurs from fluoride in the water. If you've seen this news lately, that debate is about chronic fluoride exposure. In acute exposures, fluoride binds to calcium, essentially binding up and removing calcium from the body. You can't live without calcium. It's necessary for muscle contraction and, of course, your heart's a muscle. Fluoride also binds to magnesium, thus the reason we gave some mag. It also causes potassium disturbances, mostly high potassium, though occasionally low levels. Hydrofluoric acid, or HF for short, is used in many different industries. It's used to etch glass, a practice that actually started in 1670. It's used in the semiconductor industry, for electroplating, and in the petroleum industry to produce high-octane fuels, just to name a few of its uses. Industrial exposures are typically high hydrofluoric acid concentrations. It's available in lower concentrations for home use, and that's typically 6 or 12%, used for rust removal and brick cleaning. What we typically see in the emergency department are local exposures with burns on the hands or the fingers. A really common scenario is someone cleaning bricks, then develops hand pain afterwards. HF is extremely permeable, penetrating deep into tissues, and in this case, the burns and the pain are thought to be the result of precipitation of calcium fluoride. The patient often presents with what's called pain out of proportion. Medically speaking, this means someone complains of intolerable, excruciating pain without any physical exam findings because the burn starts deep inside. Interestingly, you can guess the concentration from the time of onset. Exposure to high concentrations results in immediate toxicity, as with our patient. Patients with extremity burns often don't have pain for several hours after the exposure, as the symptoms are delayed with lower concentrations. So back to systemic toxicity. It is fortunately rare, but obviously lethal. It doesn't take much exposure to result in systemic toxicity. Shockingly, if you get 100% hydrofluoric acid on 2% of your body surface area, this is a lethal exposure. For reference, take a look at your hand. That's approximately 1% of your body surface area. HF exposure can occur via any route, including skin, eyes, inhalation, and ingestion. And as I said, systemic toxicity results in essentially binding up of all the calcium and magnesium in the body, and thereby causing ventricular fibrillation and cardiac arrest. Unfortunately, once this cascade starts, it can almost never be stopped. There's no test for hydrofluoric acid. Quite frankly, patients with systemic exposure won't survive long enough for any test results, and those with local extremity burns will improve either way. This is a question for the medical professionals. Our patient continues to have an unresponsive mental status and clearly needs to be intubated. What medicine would you avoid in this patient during intubation? A. Succinylcholine, B. Ketamine, C. Rocuronium, or D. Etomidate? The answer is A. Succinylcholine is contraindicated due to the risk of hyperkalemia. The patient loses his pulse and is in VTAC again. You continue pushing amps of calcium, you intubate him, continue shocks, and continue CPR. This brings us to an area of medicine we sadly don't know much about. CPR and advanced life support is, of course, what we do for everyone. It was designed, though, for patients with cardiac arrest due to heart disease. It wasn't designed for cardiac arrest from cancer, toxins, or any other causes. And it's extremely difficult to conduct research on these patients due to issues of consent, inability to do randomized controlled trials, and the rarity of cases, especially in the case of things like hydrofluoric acid toxicity. Obviously, we'd throw everything in the book at this patient, but the bottom line here, electricity isn't going to restart his heart if he doesn't have any calcium to contract properly. Either the calcium and maybe the magnesium is going to work, or it isn't. While we wait, hoping for a miracle, let's talk about treatment for other routes of exposure. Treating HF burns is one of my favorite things. It's a lot less depressing and it's very rewarding. The treatment is topical calcium gel. This exists in the US, but most hospitals don't actually have it. So, what would you do? It's probably the only scenario in medicine where I've mixed up my own concoction to treat a patient. Essentially, you take calcium gluconate, the liquid IV form we discussed earlier, and you add it to petroleum jelly, called Surgilube in the hospital and Vaseline at home. Every hospital has this for rectal thermometers, etc. So you mix them together and you apply the paste to the affected areas. With the fingers, you can smear it all over and cover it with a glove to really get it to soak in. This helps with the tissue damage and it treats the pain, so it's really cool. And the amazing part is that the topical application reduces pain better than IV pain meds like morphine. You can reapply it every 30 minutes until the patient starts to feel better. Another side note, once you mix it, apply it immediately. I learned this the hard way once while teaching an intern. They had a lot of questions, and by the time I answered them all, the calcium actually precipitated back out of the Surgilube, leaving us with a weird powdery goop. For inhalational exposures, you can give nebulized calcium gluconate. Nebulized is like an asthma breathing treatment. Its efficacy, not clear, but since it has no side effects, I'd give it anyway. What about ingestion? Patients have ingested hydrofluoric acid both intentionally to commit suicide and in several horrific pediatric cases unintentionally after it was left out in a glass. These cases are almost universally lethal and require a difficult decision. You could pass a nasogastric tube into the stomach to try to suck out the HF, essentially pumping the stomach. Given that this is incontrovertibly a life-threatening exposure, it might be a good idea. The flip side is blind placement of nasogastric tubes is contraindicated if there's a risk of perforating the esophagus. Swallowing hydrofluoric acid definitely carries a risk of perforation. So it's kind of a rock and a hard place decision. In addition, the procedure poses a real risk to you and your staff because you could become exposed to the hydrofluoric acid you're sucking out. If you decide it's worth the risk, PPE is a must. I'd also put calcium down the tube after you were done in the hopes of binding more of the fluoride. One astonishing case reported successful treatment of a patient dying from hydrofluoric acid exposure to one limb, and the patient reportedly survived after amputation of the limb. I had to share this with you not because I recommend this approach, but because it's quite an interesting case. Other methods of calcium, such as intraarterial injection and beer blocks, have been used in the past, but are associated with significant morbidity, and they're not generally recommended. Back to our patient. Despite maximal therapy this time, he doesn't get a pulse back. You call the pharmacy for more calcium again. They tell you you've used up all the calcium chloride in the hospital, so you switch to calcium gluconate. The pharmacist calls back saying this too is about to run out. At this point, the patient has been in cardiac arrest for 45 minutes. It's medically futile and he's almost certainly brain dead by now. You say the last words traditional in a code. Anybody have any more ideas? The team shakes their head and you pronounce the patient dead. The driver hasn't moved. He's staring in shock. This is a fictional case, as are all our cases to protect the innocent. However, it is based on real cases. With significant exposure and systemic toxicity, the likelihood of surviving hydrofluoric acid is nearly zero. The rapid action of HF here is not fictional at all. A terrible case in New York City occurred with 2 sanitation workers. As the arm of the trash truck came down to compact the load, liquid sprayed on them. One died immediately before EMS could even arrive, and the other suffered extensive complications. Someone had thrown out a container with hydrofluoric acid into the regular trash, and as the bags were compacted, the liquid shot out, spraying both men. What can be done to prevent exposure in the workplace? Safety measures, including corrosive-proof suits and scuba tanks, work. Let's get back to the issue of why the driver didn't know what they were using. Shouldn't he have known? Yes, absolutely. But there are a number of issues related to dangerous occupational exposures. Under OSHA rules, workers are supposed to know what they're working with, and quite frankly, in my experience, this is often not the case. That's problem number 1. Problem number 2 is workers do know what they were exposed to, but are not forthcoming with the history. I've experienced this with workers with local burns cleaning bricks. Patients may not want to report an occupational injury for several reasons. Sometimes they're undocumented, sometimes they're paid under the table, sometimes they're worried about losing their job, or they simply don't want trouble for the boss or the company. An OSHA investigation into our patient's workplace finds numerous hazards and violations. The company is shut down for the safety of the other workers, though 30 people, including the driver, lose their jobs. The last question in the podcast is today's pop culture consult. Hydrofluoric acid was used to dissolve bodies in what movie or show? A. Goodfellas, B. Breaking Bad, C. The Sopranos, D. Men in Black. Follow the Twitter and Instagram feeds, both at PickPoison1, and you'll see the answer when I post it. Remember, never try anything on this podcast at home or anywhere else. Thanks so much for your attention. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available on the website at pickpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Thank you. Until next time, take care and stay safe.
This podcast is a production of Unfiltered Studios. If you would like to know more about joining Unfiltered Studios, please visit our website at unfpod.com for more information.